Renal failure and coma. Scenario: a 34-year-old man is found collapsed at home 18 hours after spending a night on a drinking binge with friends. You are the junior doctor on duty in the emergency department when he is brought to the resuscitation room. There is no other history available. Examination. Your initial assessment is as for anyone in coma. Airway, breathing and circulation, ABC. Disability, neurological assessment Glasgow Coma Scale, GCS, and pupillary responses. The initial assessment reveals the following. The patient's airway is patent, he is breathing spontaneously with a respiratory rate of 12 breaths/min and his arterial oxygen saturation, measured by pulse oximetry, is 99% on high-flow oxygen. His heart rate is 120 bpm, with BP 87/45 mmHg. His GCS score is 10/15, i.e. eyes 2, voice 3, and motor 5. His pupils are normal size, equal and reactive. What is your next step? ABCD is followed by E, exposure. Make a thorough examination of the patient, which reveals that he looks dehydrated, has a tender tense swelling of the right arm, and the hand is discolored but warm with palpable pulses, Fig 21. More information becomes available. He is catheterized by one of the nursing staff and passes a small quantity of dark brown urine. The laboratory phones through the results of urgent blood tests, which demonstrate potassium 7.2 mol/L, urea 15 mol/L, creatinine 430 mol/L, phosphate 3.6 mol/L and corrected calcium 1.85 mol/L. The diagnosis is clear. Rhabdomyolysis is responsible for his renal failure, with muscle breakdown originating from the right arm, which was injured by ischemic compression during coma. The electrolyte results are typical: hyperkalemia, hypocalcemia and hyperphosphatemia. The causes of rhabdomyolysis are shown in Table 11. Excess alcohol and drug overdose are common contributors, as seems very likely in this case. Rhabdomyolysis. Suspect an unexplained renal failure, particularly if associated with coma. Look carefully for evidence of muscle damage or limb ischemia. Investigations. ECG. Hyperkalemia is often severe in renal failure associated with rhabdomyolysis. Urine dipstick and microscopy. With rhabdomyolysis, the urine looks brown, like a cola drink, and registers strongly positive for heme on dipstick testing, although there are no red cells visible on microscopy. Creatine kinase. Measure whenever rhabdomyolysis is suspected. A grossly elevated value, greater than 10,000 U/L, with a normal upper limit of 180 to 200 U/L, establishes the diagnosis. A less elevated value is consistent with it but not diagnostic. Arterial blood gases. Metabolic acidosis is expected. Toxicology. In the comatose patient and/or where drug overdose is a possibility. NB. In rhabdomyolysis, serum potassium rises rapidly and can be life-threatening. Phosphate rises rapidly and calcium is usually low. Creatine kinase is massively elevated, as are other muscle enzymes, aminotransferase and lactate dehydrogenase. Management. Close clinical monitoring. Aside from regular checks of vital signs and urine output, keep a careful watch on the arm. Apart from the swollen tender muscles, examination should look for distal neurovascular compromise, skin color and temperature, capillary refill, pulses and sensation, if and when the patient regains consciousness. Close biochemical monitoring, regular measurement, at least every 12 hours, of electrolytes and renal function tests. Hyperkaliemia can develop rapidly in this context. The following are the immediate issues. Standard measures to manage the unconscious patient. Initial management of hyperkaliemia. Monitor hourly urine output, via urinary catheter. Aggressive fluid resuscitation to correct intravascular volume depletion, with the aim of achieving a urine output of greater than 100 ml/hour. Get surgical/orthopedic help quickly. Urgent fasciotomy or debridement may be needed to treat compartment syndrome and save the ischemic limb. Compartment syndrome refers to ischemic compression created by swelling within a muscle group that is constrained by facial planes, resulting in necrosis of the muscle with or without compromise of the distal limb circulation. Further comments. What about urinary alkalinization? Myoglobin is more soluble in alkaline urine, pH greater than 6.5, and urinary alkalinization has frequently been used in patients with rhabdomyolysis. This is achieved by intravenous infusion of isotonic, 1.26%, sodium bicarbonate as part of the fluid regimen, but there is no controlled trial evidence that this is better than resuscitation and maintenance of diuresis with 0.9% saline. However, bicarbonate infusion can worsen both hypocalcemia and fluid overload, and is perhaps best reserved for hyperkaliemic, volume-replete patients with an adequate urine output. When does the patient need dialysis? Standard indications for dialysis apply, but note that metabolic disturbances can worsen more rapidly in patients with rhabdomyolysis than with other sorts of renal failure, so consult renal services sooner rather than later. Dialysis does not remove myoglobin. Who should be investigated for an underlying muscle disorder? An underlying muscle disorder should be considered if the patient presents without a clear precipitant, if there is a preceding history of increasing or intermittent muscle fatigue, or if there is a clinical picture suggestive of an inflammatory process. Diagnosis is usually by muscle biopsy.